My name is Jesse Jorgensen. I'm a general cardiologist and an interventional cardiologist, which means that I spend a lot of my time putting in stents and fixing blockages. And I'm here to speak to you today about recognizing the signs and symptoms of heart attack, and also some tips to try to prevent that from happening. And I'm going to do this a little bit differently than maybe the way I've done this talk in the past. So I'm trying kind of a new approach out on you guys. I thought what I would do, now that we're with excuse me, Carolina Cardiology in Easley, is kind of show you the inner workings of what actually happens to a heart attack patient and how we treat that. And just to give you some perspective on how much this affects your community, we treat about between 300 and 350 heart attack patients a year at Greenville Memorial. In the last 2 weeks, we've had 3 from the Easley community that have come over for heart attack care. So I'm going to kind of show you guys a couple of cases and show you some actual pictures and show you how we deal with this common and serious problem, and then we'll spend some time talking about prevention, and then there will be time for questions, because I suspect many of you might have some. The sky's the limit. We can talk about whatever y'all want to. So this is a depiction of a middle-aged man having a heart attack. If I had a nickel for every time I've heard this, I'd have a lot of nickels. But this depicts a man having the typical symptoms of a heart attack: chest pressure, chest tightness. As far as warning signs, and we can get more into this if y'all would like to, it's interesting that most patients who are having a heart attack don't actually describe chest pain. It's usually a peculiar symptom that they've never obviously felt before, but it's not pain. The most common things would be, as depicted here, vice-like pressure, or a constriction, or probably most commonly is a crushing type sensation, like someone is sitting or standing on their chest. Women and elderly patients, so patients above 65 or 70, tend to have more atypical symptoms. So we see patients not infrequently who present with belly pain or nausea and not have any chest discomfort to speak of. It's important to be aware of both the typical symptoms and some of these atypical presentations, and also, especially if you're in the category who tends to present in an atypical fashion. So the woman over age 65 would be the typical setup, and also diabetics. This is kind of a busy slide. People often wonder what causes a heart attack. This is this shows what happens within the wall of an artery. There was an interesting study done several decades ago now, looking at young men who served in Korea who died and had autopsies. And when you looked at these young, otherwise healthy men, many of whom who smoked, you found these fatty streaks, or these lipid deposits that we refer to as atherosclerosis. And that study that was done several years ago taught us that this process begins very early in our lives, particularly in the United States. That's probably related to our diet and other habits that we'll get into later, like tobacco use. This process starts very early, and what's interesting, and I hope you can appreciate, is that a normal artery, which is a perfectly round structure, if you just look at the artery itself, it looks exactly the same. So our arteries in the heart and elsewhere in the body have I think a kind of a fascinating ability to grow out to accommodate a large amount of fat and cholesterol and plaque buildup within the wall of the artery. So this process progresses over years. You have to build up a fair amount of plaque to the point where it actually creates a significant narrowing. What I'm going to focus on with you guys is not so much this process, which happens over years, where you have progressive plaque buildup and more plaque buildup and more plaque buildup. we're going to talk about what happens when you have a relatively mild narrowing with a significant amount of plaque buildup, where there is what we call plaque rupture, where that area of plaque buildup erupts kind of like a volcano and causes a clot to form. So this is what we're going to talk about. 30% blockage maybe, that in a split second becomes 100%. And this is what we see at 3 in the morning with a heart attack. Patient coming in with an artery that's completely blocked off. So I'm going to show you guys 2 cases from Easley. These are recent. The first one is a 57-year-old gentleman who developed chest pain, came into the ER here kind of late afternoon, 4:17 p.m. A heart attack was recognized. We recognize this based on the EKG. This is something you might see on a billboard or in the newspaper, this term STEMI, which is in our field how we refer to a heart attack. It stands for ST elevation myocardial infarction, which is just the how we describe the EKG finding. So this was found on his EKG, and he was transferred by Pickens County EMS straight to our cath lab at Greenville Memorial Hospital. So the idea is when a patient is recognized as having a heart attack, the clock starts ticking, and the longer you wait, the more heart muscle cells die. A lot of people have been through a heart catheterization before. A lot of people who haven't wonder what it entails. This is an artist's rendering of what we do in the cath lab. It's not exactly like this. This patient kind of has a loincloth draped over them and is otherwise bare-chested. We keep it pretty cold in the procedure area, so this patient would freeze to death if we did this, but it gives you a general idea of a cardiologist and a patient with the x-ray cameras and a catheter that's kind of coming out of the groin area, and the cardiologist is looking at the x-ray screen as the catheters are manipulated within the body, and x-ray dye is injected in order to see the area of blockage. These are the general ways in which we go about doing a heart catheterization. The traditional way involves going in through the femoral artery in the groin. These catheters are typically around 2 millimeters in diameter, so this is about the size of a kind of a smallish drinking straw, and the catheter is advanced up what we call the femoral artery, and then the aorta, and around the arch of the aorta. And these catheters have special shapes that allow them to fit into the right and the left coronary arteries. A newer approach that's been developed within the last decade or so that's becoming much more common, and some of you may have had the procedure done this way through the artery in the wrist or know someone who has. This has become very popular because it allows for so if you've had this done, you can sit up immediately. You don't have to lay flat afterwards. There's no sandbags and mashing on the groin. It's a much more pleasant experience for the patient, and also the bleeding risk is low. So this is becoming much more common and more popular among doctors and among patients. Several of us have started doing even emergency heart cath procedures through the wrist, and so if you very successfully, if you compare what we're doing in 2012 with 2 decades ago, it's a tiny incision in the wrist rather than a big incision in the chest. So it's what we're able to do in a much more minimally invasive approach, I think, is remarkable. We struggle with that sometimes when we talk to patients about changing their behavior. It was easy before because you had a big scar to serve as your reminder, whereas now hardly even a scar in the wrist, sometimes people forget. Can you see your spot? Oftentimes there's a little red dot in that area, so invisible. That's how we like it. We were talking about angioplasties a little while ago. People wonder about, well, we used to do angioplasties. Do we do angioplasties anymore now that we have stents? I hope this projects okay. Actually, is it possible to turn the lights down in the front? If you guys start to fall asleep, I'll come and nudge you. This yellow stuff represents plaque buildup. This is a very small wire across the blockage. This is how we do a stent procedure. This represents an inflated balloon, and I'm going to show you this in a real-life case in a second, that pushes that plaque out of the way And in this case, they did a balloon. We call it POBA. It stands for plain old balloon angioplasty, is the official term. Pushes the plaque out of the way. This was how things were done 20 years ago, and that was the end of the procedure. These days, we go back in with a stent, which is crimped down on a balloon, and as the stent is expanded by the balloon, and then the balloon is deflated and removed, the stent is left behind to keep that blockage opened. And so this is how an angioplasty or a stent procedure works. So this is our patient, and what I'm showing you is that patient's angiogram of the right coronary artery. And this is kind of the moving pictures. This is the catheter injecting the contrast dye. This right coronary artery should be a C-shaped structure. So this should continue all the way down to the bottom part of the heart. And I hope you can appreciate it stops right here. So there's a couple little branches that come off, but this artery should continue on down. This represents a stent being deployed, and so in the cath lab we put a small amount of contrast material in the balloon as we inflate it, and it allows it to show up on the x-ray pictures. This is a stent being deployed, and this is what a normal right coronary artery should look like. So the stent is deployed in this area, and so this patient's problem is fixed. So this area, the reason for this obstruction is clot formation. The stent has pushed that clot out of the way and restored normal blood flow. This is probably the most rewarding thing that we do as cardiologists, because this problem on the left is something that can kill you quickly. In addition to all the severe symptoms that it causes, this is immediate gratification. So patients better right away. So this is one thing that you might see advertised or on the news, the so-called door-to-balloon time. In the era of Twitter and Facebook and new terminology, this D2B is our abbreviation for the door-to-balloon time. The standard that's been developed for all of us to aspire to is to get an artery open within 90 minutes of that patient coming through the hospital door. So if a patient comes into our emergency room over at Memorial, we want that artery to be open in less than 90 minutes. In the old days, it wouldn't be unusual for that patient to wait maybe 20 minutes on the EKG to be done, and then you have to wait to get someone to actually look at the EKG, and oh, it's 2 in the morning, no one's around. Well, let's call the cardiologist to come look at the EKG, and as all this time goes by, heart muscle cells are dying. And so this has become the national standard so that we don't waste time getting someone to look at the EKG. If there's a heart attack, you jump on it quickly. So this is the national standard. Just to give you an idea of what's happening here at Easley and with our partnership with Easley and at Memorial, this patient, this is another new term, DIDO, door in, door out. So how fast did the ER here turn that patient around? So from the time they walked in the door to EKG being done, interpreted, and then out the door in the ambulance or in the helicopter, 25 minutes. That's pretty good. We also look at our door-to-balloon time at our hospital. So from the time they rolled in our door to the time the artery was open is 12 minutes. And I don't know if, to me, that's a very short period of time when you consider that patient has to be brought in, put on the table, draped, prepped, sterile, getting in the artery, taking the pictures, and an artery open. I didn't do this procedure, one of my partners did. 12 minutes is pretty darn good. So when you look at the total time patient coming in to the door at Easley to actually artery being opened up at a hospital several miles away was 74 minutes. So this is better than what the national standard is for the patient that rolls into your hospital where you can do the balloon on site. So this is really, really good for a transfer patient. This is a tribute to the excellent ER here, Pickens County EMS, and the team approach to taking care of sick patients. I'll show you the second case, and this is just a little bit of a different scenario. This is a 61-year-old male, and ladies, I don't want you to get the idea that y'all are immune to this problem. It just so happens that these two cases were men in their 60s. So this guy called 911 from home. And so he didn't come into the ER. He called 911. EMS came to his house. This is another case from recent. The Pickens County EMS team shows up in the ambulance at his house at 10:42. So this is remarkable in that this is off hours. So this is the time when a lot of doctors are at home. There's the usual staff is not there, ready to take care of the patient. The EMS team did the EKG in his house and is able to diagnose a heart attack without even bringing him into the ER. And so one of the really cool things with modern technology is that the ambulance now has the ability in many cases to get the EKG, interpret it themselves, and activate this process where we bring the team in and also transmit the EKG immediately. So this EKG can be sent from the patient's house directly to our ER. So if there's a question, the ER doctor and or the cardiologist can look at it. I've had these EKGs sent to me on my smartphone at home by the ER doctor. So this is one of those things that just saves time. And we have a saying that time is muscle. So this patient had his heart attack or STEMI recognized in the field and was brought directly to our cath lab. And I'll show you this case. This was less dramatic. This patient, this is also a right coronary artery, so you guys are all going to be right coronary artery experts at the end of the talk. But this patient was lucky. The artery was not completely blocked. It had about a 90% narrowing that was opened up again with a stent. And this is what the artery looks like at the end. So this was a case of a patient being brought in from home directly at 11 o'clock at night, and the artery was open within 35 minutes, which is really, really good. Both of these patients did great. They're home within 3 days. So those are the cases. So I want to kind of take a step back and give you a sense of why we think this is a growing problem, treating these heart attack patients, not only in this country but also in South Carolina. Teresa's seen these slides now many times. It's one of my favorite sets of slides, but this series of about 15 slides illustrates, I think, what, if you could identify one problem, I think this is it. So this is not a map of Republican presidential primary results, although it kind of looks like that. This is something that the CDC started putting together in the mid-'80s, looking at the trend of obesity in our country. And so in 1985, they went out and collected data on what percentage of the population is obese. And on one of your cards that's in front of you has something called the BMI, or the body mass index, which is a calculation of whether you're overweight or obese or at your ideal body weight that's adjusted for how tall you are. So it's basically your weight in kilograms divided by your height. In 1985, the key is down here. So the white areas they didn't have information on. So they started from scratch. But you could see that South Carolina was already leading the pack. Between 10 and 15% of the South Carolina population was obese in 1985. Georgia was with us, and then you can see these other states that kind of shared the burden. The light blue is less than 10%. What I'm going to do is kind of show you year by year how this the incidence of obesity is really spreading like an epidemic. And so this is over the past 2 decades. So by 1991, we have a new category. As we go along, there's going to be several new categories that show up. So almost a fifth of the population is obese in Louisiana, Mississippi, West Virginia, Michigan. 1994, 1996. 1998, there's a new category. It's more than 20%. South Carolina, again, is leading the charge. 2000. New category again, so more than 25%. 2004. 2005, another new category, more than 30%. People must really exercise a lot in Colorado because it's the only state that's still hanging on to less than 20%. Okay, so this is the 2010 is the most recent year that there's data, but I think this is a major issue. Why does this matter? So this is why, right? Why does this matter? So if you break it down by age, if you break it down by age and also look at children over time, so on the slide on the right, we tend to get less physical activity as we get older. That tends to make common sense, but if you compare people between 18 and 24 with people over the age of 75, as you get older, you get less and less routine physical activity. That makes sense. What's disturbing is that if you look at this graph and what this represents on the bottom, the data points, this was in the 60s, this is in the early 70s, mid 70s, early 90s, late 90s. This is just looking at kids, is that in the 60s, about 5% of kids were overweight. And as you go along into the 90s and now into the early 2000s, that number has tripled. So not only do we get less active as we get older, our children are less active, and the obesity problem is starting out at a younger age. And so the stuff that keeps us busy on call, on nights and weekends, I think is only going to continue to be the case unless we do something differently. So why does the obesity thing matter? Why do we care? This looks at several health conditions, diabetes, this cholelithiasis is gallstones, high blood pressure, heart disease. As your body mass index increases, the incidence of all these things also increases. This is for women and this is for men. So this stops at a BMI of 30. This group of patients wouldn't even have shown up on those maps that I showed you. So these are for relatively skinny people. This trend continues when you get past a BMI of 30. So I think the key thing and part of the message to you guys is thinking about ways that we can try to reverse this trend, for not only for ourselves but for our young family members and people we care about. This is interesting. Behavioral causes of death. Tobacco leads the charge. And then diet and activity patterns is number 2. Everything else that gets a lot of attention and dollars, illicit drug use, gun control, these things pale in comparison to tobacco and diet and activity patterns. So I think the solution is to eliminate tobacco, regular aerobic exercise. We talk, or I talk with my patients often about trying to get this 35 rule, 30 minutes of aerobic exercise a day, 5 days a week. If that can be your goal, no matter what it is, that'll get you on the right track. It's very easy to talk about, very difficult to implement. And even in those 2 patients that I showed you that came in the midst of a heart attack, we refer 100% of those patients to what we call cardiac rehab, which we have a good program in Greenville. There's an excellent program also here in Easley. It's a 12-week program of basically boot camp for a heart attack patient or a bypass surgery patient to get going on an exercise program, diet, smoking cessation, these sorts of things. Because even after a heart attack, it's not too late to start with this type of program. So quit smoking, exercise, diet. I am not an authority on different diets, but I talk about it with patients every day. So I don't know, maybe I am an authority now. There's several out there. People want to know what should I do? Should I do Atkins or South Beach or any of these? I'll tell you the ones that people tend to have success with, both in the short term and also sustain, I've found are Weight Watchers. I push the Mediterranean diet because it allows you to eat good food and enjoy it without having to worry about whether I'm eating too many carbs or not. And I put this Engine 2 up here. Just has anyone heard of the Engine 2 diet? I have one of my partners lost 40 pounds on this diet. I first heard about it and I thought it was a gimmick, And it kind of is, but it works. It's basically, it was written by a firefighter, and that's kind of the source of the title, but it basically involves becoming a vegetarian and cutting out red meat. And he has success with it. So I put it up there just to point out that it doesn't really matter what you pick as long as it makes sense and you're able to stick with it. Atkins, people tend to, you can lose a lot of weight in the short term, like if you're trying to fit into a wedding dress that's, you know, the wedding is 6 weeks away, but Atkins is hard to sustain because you just crave a loaf of bread. You crave the carbs. Know your numbers. I think this is important. This is on one of the laminated cards that Teresa passed around, is knowing not so much what your BMI is. I don't think you have to calculate the number. I think most of us can kind of look in the mirror and know if you're where you should be or not. But things like your blood pressure and your cholesterol, it's remarkable. Sometimes meeting a new patient, for example, in our Easley office, which happened recently, bypass surgery 10 years ago, patient couldn't remember the last time he had his cholesterol checked. Seems like common sense, but sometimes these things fall through the cracks. That's our job, but you also want to be empowered to know what to ask your doctor. And then know the warning signs of a heart attack, which we talked about, the symptoms. Don't ignore it. Don't just chalk it up to the worst case of indigestion you've ever had. You want to get attention early, and we preach don't drive yourself. I've talked enough. I hope this was interesting and informative to you guys, and I intentionally saved a little bit of time to give you guys a chance to ask some questions.